okay, I have a patient that has a saphenous vein, but I'm still going to do endovascular. My name is Peter Schneider. I'm a vascular surgeon in San Francisco. I'm here at the PVI Congress in Paris here in December 2025. And this has been a fantastic meeting so far. One of the topics that I'm covering during this meeting is this concept of, okay, I have a patient that has a saphenous vein, but I'm still going to do endovascular. Could that be incorrect? Could that be correct? Well, let's think about that for a minute. So where this question really comes from is from the BEST-CLI trial, which was published a couple of years ago in the New England Journal. This, of course, was a landmark trial. And in this trial, the patients were only chronic limb-threatening ischemia, or CLTI patients. This is the largest ever prospective randomized controlled trial of CLTI patients. And they were compared in two different cohorts. One cohort had an adequate saphenous vein, that is, meaning that it was a reasonable saphenous vein to be used for a bypass. The other cohort did not have a reasonable saphenous vein. They only had alternative conduit. And it turned out that in this randomized trial where best endo versus best bypass was being compared, that only the patients in cohort 1, where there was a reasonable saphenous vein for bypass, these patients turned out to benefit from bypass. So if you have a patient that's just as described in that cohort 1, that is, they're fit for surgery and it's a reasonable choice for bypass and they have a saphenous vein, the idea is that you should go ahead and do a bypass because there's a lower rate of major adverse limb events or major reintervention in that population. So taking it yet another step further, how do we translate this randomized controlled trial data into real world practice? And in fact, in real world practice, I get a lot of patients that were not terrific for the BEST-CLI trial inclusion. And this is because many of the patients that I see are unfit for surgery. You see, to be in the BEST-CLI trial, you had to have a reasonable health or reasonable fitness to have a major operation. So many patients I see are not fit for surgery. Many patients that I see have disease morphology, which is actually rather straightforward for endovascular and would not have been included in the BEST-CLI trial because these are patients that it would have been too much. It would have been going overboard to offer them bypass for relatively simple lesions. And I think the bottom line and the, let's say, the punchline of the story that I can tell based on my own practice and my interpretation of the BEST-CLI trial and how it works in real life is that if I have a patient that has a good saphenous vein and they're also fit for surgery and they also have class 3 anatomy, that is quite complicated disease morphology, typically involving both long segment occlusion of both above the knee and below the knee. And they're also a WIfI 4 in terms of presentation, which typically means severe tissue damage in the foot. And it's quite urgent to do everything we can to restore blood supply. This is the patient that I would consider a bypass. All the rest, which is the vast majority of patients, probably 80% or more, should be treated with endovascular. And many of those patients will have a good greater saphenous vein, which of course was the whole point of the discussion. The patient has a good saphenous vein, and yet I decide for one reason or another clinically that it's not appropriate to do a bypass. So thank you very much. We're here at the PVI Congress, and seems to be quite an excellent meeting with a lot of enthusiasm and a lot of people looking forward to the holidays. Thank you.